Let's start out where I get a lot of questions from people, and that is children. Where are we in the process of getting a vaccine approved for children? Are we within days or maybe a couple of weeks?
Well, as you know, when you talk about children at different ages, for the Pfizer vaccine, certainly, what we have is a approval to be able to give vaccines from children 12 years old and over. Right now, a study was done to look at the safety, the immunogenicity, and the potential effectiveness of vaccines for children who are 5 years to 11 years, and even younger, but for the purposes of discussion, the 5 to 11 elementary school kids. Those data have been accumulated. The advisory committee to the FDA, which is called VRBPAC, will be meeting in a few weeks to go over those data and to discuss it. That final decision will depend, David, on the very careful examination of that data for what we call the safety, immunogenicity, efficacy, or what the benefit-risk ratio is in giving approval. So I can't predict if and when there will be approval, but the only thing we do know is that the advisory committee meeting with the FDA will take place in a couple of weeks.
So, Doctor, you have said to us throughout this process that it can't be anything more important than the safety of what we're doing as well as the efficacy of it. So I'm not trying to rush it. I want to make sure it's being done right. At the same time, people are eager just to set realistic expectations, and we don't know how the study will come out and what the FDA will do. But realistically, are we really talking about the end of the year? Could it be as early as Thanksgiving, do you think?
You know, David, it could be, again, it's given the environment in which we are and living right now, that if you say one thing, it immediately gets taken completely out of context. You're getting ahead of the FDA or not. Let's let the process play out. There are certain things that I can say for sure, is that the FDA's advisory committee, VRBPAC, are looking at the data and will meet with the FDA very likely in the next couple of weeks. How long that takes for a decision for the FDA, the only thing I could say is the FDA takes that very seriously. They will do it as carefully and as expeditiously as they possibly can. But when you're dealing with a regulatory agency who has the responsibility for the safety and the availability of these types of interventions to the American public, you don't want to get ahead of them. You want them to do their job. And it is likely they're going to do it in a very competent and expeditious manner.
So let me try a different one, and that's boosters. A lot of talk about boosters. We have some approvals for some boosters. And most specifically, what about what I will call mixing and matching? That is to say, somebody who got particularly a J&J, Johnson & Johnson vaccine, perhaps being able to get a booster from a Pfizer-BioNTech or from Moderna. Where is that process? Because I understand there are some studies being done on that.
Well, there are. We here at the National Institutes of Health, in my institute, the National Institute of Allergy and Infectious Diseases, have done a study, which is a 9-part grid study. So what it is you take the 3 products that we know are available for vaccines that we're giving now in this country: Pfizer, Moderna, and J&J. And what the study does, it gets individuals who've been given the classic dose, which is 2 doses for the mRNA and 1 dose for J&J. And then what you do is you use as the booster either Moderna against each of those 3, J&J against each of those 3, and then Pfizer against each of those 3 to determine just what we've mentioned before: the safety, the immunogenicity, and the ultimate efficacy of those kinds of mix and match. To answer the question, if I get a Moderna, can I be boosted with a Pfizer? Or if I get a J&J, can I be boosted with a Moderna? Those studies have been done. The data have been presented in a package to the FDA, I believe. I don't have the exact minutia of that, but the data are being examined by the FDA, and they will in fact examine it and look at it and make the same determination that I mentioned for the other issues that you brought up. They will examine the safety, the the immunogenicity, which means its ability to induce a particular immune response, and whether or not they will give an approval that you can use this product with that product, et cetera. So right now it's in the process of discussing with the FDA.
Let's go to a different subject, and that is this pill that now apparently we're going to be able to take that will suppress at least this virus with people. Give us a sense of the role of that pill putting together with the vaccines, because I do wonder whether some people would say, look, if there's a pill coming down the pike, maybe I don't need to have a shot at all. Maybe I'll just take the pill.
Well, first of all, let me clarify the issue with vaccine versus pill. The pill is to treat someone who's been infected very recently within a few days. A study was done by the company, by Merck, and Ridgeback was the one who originally did it, but Merck did the study. The product is called molnupiravir, and it is, as you say, a direct antiviral agent that is taken orally. And the question was, if we give it within a few days of someone getting infected, can you prevent them from going on and progressing to need hospitalizations or death as an endpoint of the study? As it turned out, there were about 1,500 people in the study, and when they got to about 700 plus, they look at the data intermittently, and the people that look at the Data and Safety Monitoring Board said the data are impressive enough, let's stop the study. Because what it was is that the treatment gave a 50% effectiveness in preventing the progression to hospitalization and deaths. So there was 7% of the people who got the treatment went on to this endpoint, and 15% of those who got the placebo went on to the endpoint. So it was 50% better. Based on that, and also the fact that in the placebo group, there were 8 deaths, and in the treatment group, there was 0 deaths, which is pretty impressive with regard to data. But remember, this is still preliminary data. And just like everything else, you've got to look at the safety issues, you've got to look at the efficacy issues, and those types of data will ultimately be presented to the FDA to determine, and that hasn't been determined yet, whether or not that data allows one to go ahead and make an emergency use authorization. So the data look quite encouraging, but we've got to remember there are other issues with regard there. Make sure there are safety issues, make sure you get a bigger study ultimately to really confirm it. Now, getting back to your question, which is an important question, when people say, well, if you have a pill that looks promising, why should you get vaccinated? That, in so many respects, David, is a false narrative, because the vaccine prevents you from getting infected, prevents you from getting clinical disease. And we know that we have highly effective and safe vaccines. So even if you have a pill that gives you 50% greater chance of not going to the hospital or even dying, it is always something that's common sense when you say it. It is always, always better not to get infected than to get infected and having to get treatment. That goes for any disease, certainly for COVID-19.
Dr. Fauci, one of the things that you as a scientist have told us, as others have, is part of the reason it's so important to really stamp out this COVID-19 is because there will continue to be more and more variants that develop. Certainly the Delta variant has thrown us backwards. What about future variants? How concerned are you about there? Do you see any on the horizon?
Well, you know, the answer is there are many variants out there. The Delta variant has a characteristic that it is so easy and efficiently transmitted from person to person, which is good for the virus, but bad for us, that it has actually crowded out all the other variants. However, the question you asked, David, is a very relevant question. As long as you have virus freely circulating in the environment, in society, jumping from person to person, that virus, by the fact that it continually replicates, gives itself ample opportunity to mutate. And when you give it ample opportunity to mutate, sooner or later, you will get an accumulation of mutations that will lead to another variant. So that's the reason why we say the best way to prevent the future emergence of variants that might be problematic, the best way to do that is that don't give the virus the opportunity to freely spread. And we have now, I think, something like 68 million people in this country who are eligible to be vaccinated, who have not yet been vaccinated. And the negative part of that is that not only is that dangerous in the sense for themselves, their health, the health of their families, but the fact that they're allowing, even if they get infected and don't get any symptoms, the fact that the virus can enter in them, replicate, and then spread to someone else, that you're propagating the outbreak, you're propagating the dynamics of the outbreak, and you're actually giving the virus the opportunity to continue to mutate and evolve into a variant. So it's up to us. There's a lot that we can do to prevent the emergence of future variants. And one of the most important and effective things we can do is to get as many people vaccinated as you possibly can, and as quickly and as expeditiously as you possibly can.
And finally, Dr. Fauci, I want to turn to a personnel issue. As I understand it, you will be losing a close colleague in Dr. Francis Collins, the head of the National Institutes of Health. He's going to be stepping down. Talk about how important he's been in the battle. I know you've said before you've been impressed as a geneticist. He came in to deal with infectious diseases. How important has he been, and what do we need to look for as we look to replace him?
Well, I mean, Francis Collins is a world-class scientist who has had an historic tenure as the director of NIH under 3 administrations, and his accomplishments are numerous in so many different areas. The comment that you made, reflecting what I said to the press, is that one of the many, many positive aspects of Dr. Collins is his ability to adapt and be value added to any scientific discussion. And the point that I was making is that he's fundamentally a geneticist who has major contributions to the field of medical genetics. However, when the COVID-19 crisis came, he partnered with me and just became a really day-by-day partner in addressing areas of infectious disease, of immunology, so that he was totally value added to our effort. And that's something that in some respects is unusual, that you can get someone who goes out of their known classical field of medicine or science and does a lot of really good. And we've had, we've worked together literally on a daily basis now for almost 20 months. And obviously it's going to be, I'm going to miss him terribly because he's such an extraordinary individual. What you look for to replace him is someone who has those kinds of characteristics, who are a serious, well-established scientist, who's an entirely credible scientist, but also who understands that you have to provide leadership qualities to essentially be the leader of multiple. We have 27 institutes and centers here at the NIH, one of which is my institute, Allergy and Infectious Diseases, which is the second largest of the institutes at the NIH. And there are a lot of different disciplines, a lot of different health problems. You have to have somebody that can negotiate that can interact with the Congress, that articulate public health and scientific principles to the public. So you have to have somebody that has all of those qualities that Dr. Collins had plenty of and in depth.